and Norman Weinberger. And from the staff, we have myself, Dana Diamore, we have Megan Fogno, Aniela Fignon, and Brian Weeks. We do not have a quorum, so we aren't gonna approve the first item. We're not gonna talk about the minutes. We can move that on to the next agenda, to next month's meeting. So I'm gonna start off with the director's report. So the budget process continues. Tomorrow night, there's a public hearing for the operating budget. If you remember, we originally scheduled this meeting to be tomorrow because we were trying to stagger morning meetings and evening meetings, but we did that without realizing there was going to be an operating budget public hearing tomorrow night. So that's why we had to move this month. So thank you everyone for being understanding about that. So the budget process continues. It's looking great for our requests. For the recommended budget, we did have to make some cuts. The mayor asked everyone to make a 0.5% cut out of their budgets to save money. So we're able to make those cuts. So we'll see after the public hearing tomorrow, and as the process continues and finalizes. But feeling really great about our budget for next year for the operating budget. If you remember, we had put in a request for the epidemiologist position to be city funded, and so that's the main highlight. We did move because of after the city's reorganization and the early retirements and the different positions that were added and changed. We did move some positions within the different divisions and the line items. So some look like they went up a lot, and so it's hard to tell in that document, but so we were able to move people around where they belong. So we made some of those changes as well. Our community health assessment, we're partnering with the hospital, New Vance Health, Norwich Hospital, and other community partners. That process is going to be starting up soon. Some of the initial data collection has been occurring with Data Haven, the community wellbeing survey, and we're going to be meeting with our partners soon to plan out the next phases and figuring out how we can support that process and begin community engagement and updating all of our community health priorities, and then eventually updating the community health improvement plan. Dr. Weinberger had asked for an update on childhood immunizations at a board meeting. And so next month we will have Pam Bates, who coordinates the IAP program for us, as well as Darlene Hoffler, supervisor of clinical services. They will be on the meeting next month. And so we'll have that update in April. Wanted to follow up, Ken had asked to look at, are there any state legislation related to community health workers? So Aniela's been doing a lot of research on it. We haven't found any recent bills posted this session, but we're going to keep our eyes out on it We're working on a de-escalation training for our staff. We had done one 3 years ago. We had helped coordinate with different departments in the city, customer service training, de-escalation training. We're going to be working on updating that for our staff. We have a lot of new staff members. And we're also encouraging the staff. The CDC is providing another survey on the public health workforce, focused on the mental health of the public health workforce, those working in state, local, territorial health departments. And so we're encouraging our staff to participate in that. And we've heard from some that they've already completed it. So that's something that we're working on. We know we've talked about mental health, in particular the public health workforce. So I wanted to just let you all know that we're encouraging our staff to participate in that. And those are my updates. Any questions related to those updates? All right, next we have the COVID-19 update. Brian, are you able to present now?
Hey, good morning, everybody. Can you hear me?
Yes, we can.
Alrighty, here, let me just pull up the PowerPoint. We'll jump right into it. All right, what you should be seeing on your screen on the left-hand side, we'll start with that, is the Johns Hopkins Coronavirus Resource Center stats. So this is pulled from this morning. So the global confirmed COVID-19 cases is about 472 million plus, global deaths 6 million plus, US confirmed cases 79 million plus, and then US confirmed deaths 972,000 plus. As you can see with the right hand side here, the greenish map, and it's good that it's mostly green. This is the new community levels by county. Compared to our last meeting, this is a new update from the CDC. So it differs from the community levels of transmission by county, which is the previous map that's been shared during these meetings. That was a 4-tiered system that had the red, yellow, blue, and orange colors. And so this is now a 3-tiered system with high being orange, medium being yellow, green being low. And fortunately, and this is updated once a week, every Thursday by the CDC. And as you'll see, when you zoom in, it's by county again. All the counties, including Fairfield County, are in the low. And so this new kind of system is taking into account really a lot more hospitalizations. And so it's factoring in new COVID-19 admissions to hospitals, as well as percent occupied staffed inpatient beds at the hospital as well, along with the case rates going on in those counties, but with the new threshold of 200 versus the 100 that would get a county in the high. And so therefore, interpreting this information, there's a quick little infographic from the CDC. For low, have a plan for rapid testing. So that's required or suggested for every situation, along with obviously talking to your healthcare provider about whether you are a candidate for oral antivirals. From there, then the medium category as well as the high categories, wear a mask or respirator that provides you with greater protection, for example, KN95. And then high, consider avoiding non-essential indoor activities in public where you could be exposed. And then also in the fine print here from the CDC, at any level, people with or around those with higher risk for serious illness with symptoms, exposure to someone with COVID-19 or a positive test should take extra precautions to protect yourself and others. So those are kind of the recommendations that come out of this new system, especially prioritizing, hospital capacity and new COVID cases entering that hospital system. As well as just cases relative to the county. But this is a new system that the CDC is quite proud of. It's adjusting for obviously the kind of newer phase of the pandemic, or as we kind of transition to, especially as we're getting closer to the summertime, but now also in the spring. And so happy spring, everybody. So with that said, this is the SARS-CoV-2 variant surveillance from the CDC. And so as you may remember, the orange is Delta. But then over the weeks, obviously, you see Delta decrease, Omicron enter the picture, the different shades of purple. And then we have BA2 that we're monitoring as well as the CDC is, that's entering the picture, and it's in the pink here. So obviously the last few weeks, it's definitely increased steadily, but slowly in terms of incidence and prevalence. So as you can see here, for the most recent week of March 6th to the 12th, BA2 is about 23.1% of those new COVID cases. So almost a quarter. And then you can see on the map here for all the regions of the United States, same time period, March 6th to the 12th. The eastern and western seaboard has the largest proportion of, BA2, but also the Midwest and the South also has a decent proportion as well. So BA2 is definitely, prevalent throughout the whole country. Definitely you might have been hearing the news about internationally what's going on with European countries and in Asia too. Everybody's got kind of a mixed situation in terms of what's leading to, that surge of activity. I mean, a lot of those countries didn't experience as strong of an Omicron wave as the United States did, especially as early as the United States did. But then also their vaccination rates, especially in those that are much more vulnerable, say the elderly, like as an example of Hong Kong, they're only at like 30% compared to the United States, which is almost double, if not a little bit higher than that. So it's just something else to just keep in mind when we hear those stats. But nonetheless, we got to keep an eye on this. BA2 is spreading, although slowly, and hopefully it stays that way. But we do have a few things we got to factor in. So looking at the hospitalizations for the state, this kind of emphasizes that pattern. So the seasonality tied to COVID in the state of Connecticut. But this is data up to March 21st, looking at it for the entirety of the pandemic, COVID-associated hospitalizations. So again, you can see where we were back in 2020, 1,972. The more recent peak in January relative to Omicron, 1,939. Our newest hospital numbers from yesterday evening from the state is 97. So it's been jumping around, getting close to 100. It also got to 100. In terms of these numbers, let alone the last few data points, what's interesting is by county, Fairfield County has been the largest proportion of those daily reports. So we're at 31%, or 30 COVID hospitalizations relative to last evening. And then that is followed by New Haven County with 28 at 29%, and then Hartford County with 27 at 28%. So just want to emphasize that point. But nonetheless, the other point to hit home here is, again, we did see that bump, in late March, early April, if not mid-April, relative to potentially activities related to spring break. This is also the introduction of alpha, but nonetheless, we have other conditions such as BA2, and especially being in very popular tourist destinations like Europe, that could also potentially cause this bump to happen. And so that actually will segue to 2 slides for now. Nonetheless, as you can see, this is the map from the State Health Department for case rates by city and town. This is data looking at it from February 27th to March 12th. It's the 2-week calendar period. And so Norwalk is at 5.5 cases per 100,000. You can see how we're in the yellow. We are also have some towns that are in the red still in the orange as well relative to lower Fairfield County, but also that's also present in other counties as well. But definitely not the full shade of red that we used to be dealing with relative back to the peak of the Omicron wave. So with that said, and the point I was trying to make before, as we look at Norwalk here, you can see how, say from the reporting time period of February 17th, we are at 17.1, 11, 6.8. And then the most recent 2 weeks, we have 5.5. So again, it is somewhat suggestive that we may have hit a floor in terms of our new baseline, so to speak, in terms of COVID activity. I mean, we'll see if obviously with the newer data points that come out from the state this Thursday, if that's going to hold. But so far, it does suggest, based on preliminary data, that it will stay in the yellow, as we remember that the 5 to 9 is the yellow level, and then less than 5 is the gray level. And so just keep in mind in terms of how the other towns, or other big 7 Connecticut cities are performing. Bridgeport, Danbury, Hartford, less than 5, along with Waterbury. The highest right now is New Haven at 15, and then Stamford at 5.5, so performing similarly to Norwalk. But nonetheless, something you want to keep an eye on in terms of what's going on in terms of our current case rates. Current case activity, we had 21,387 total cases, 268 deaths. The other interesting thing here too is the last 2 calendar weeks, March 6th to the 19th, in terms of age groups impacted. So I thought this was kind of interesting, seeing the proportions. So we have tied at first place the 10 to 19-year-old and 50 to 59-year-old age group at almost 21%. Then that's followed by the usual suspects with 30 to 39, at around 18%, and then followed by 60 to 69 at 14.3%. Again, not great to see that age group dispersion, especially with younger age groups, because then again, it suggests, a lot of opportunity to spread in the household, if not evidence of it right now with this data, with, you have, your older adults, your middle-aged adults, as well as your young people. And so it's a lot of opportunity for transmission too. Again, keeping in mind that this is proportion. In terms of the actual number of actual cases, it's much lower than where we used to be, but still not great to see that age group dispersion. So it's something, again, to keep an eye on, because that means there's more opportunity for it to spread. It's not singled out in terms of one age group that's really showing a lot of that incidence of cases. But again, also all age groups are impacted too, at various levels. So again, from 0 to 80 plus in terms of this chart. So just want to emphasize that point. And again, as the CDC has said, and it's one of the most important bullet points that have come out with new community levels, is vaccination is going to be our best mitigator against severity of illness, especially those hospitalizations and deaths. But also it does help reduce infection in some cases. So it's really important to emphasize that point. And so as we see for all ages, those that have initiated vaccination since its obviously inception and availability, 88.6% initiated vaccination for the city of Norwalk, 78.12% fully vaccinated, 39.19% with the additional doses received. So again, this is going to be what really helps offset the waning immunity that we do see with the vaccine. And so making sure everybody's in tip-top shape, so if they do get exposed to the virus, that their body can respond very quickly and strongly to offset it. And so it's very mild illness, if any at all, and also that reduces the risk of transmission to others in turn. And so just emphasizing that point, it does follow a very linear gradient in terms of just following, the older an age group, the higher the number. So obviously the biggest gap here, or the lowest proportion is the 12 to 17-year-old age group at 25.2%. But keeping in mind that they come later in the process, but nonetheless there still is that low number, almost at a quarter in terms of where we're at. But again, also in terms of fully vaccinated, again, also late eligibility, the latest for 5 to 11-year-old, we have 37.5%. So I just want to emphasize those points. But again, just making sure everybody's up to date with their vaccines, right? That's the language to emphasize, up to date. It's not just about being fully vaccinated, it's about also getting those booster or additional doses relative to each person's circumstances. And then on top of that, we just want to keep an eye on flu. Fortunately for the Northeast, pretty much minimal activity relative to it. It's really more the Midwest and South that seems to have some activity, especially Oklahoma. So it's still going around, but obviously not as major concern as in comparison to, say, COVID. So it's good to see that, flu activity is lower than it was before, especially again when Omicron was at its peak, but flu was technically at its peak as well. And so with that said, we definitely want to take advantage of all the resources that we do have, and especially the excellent resources that we do have. So the city of Norwalk has, the COVID-19 testing at Shady Beach, 99 Pasture Beach Road. So definitely for those that have been exposed to the virus and are in the process of, getting through their quarantine, or for those that, maybe experiencing symptoms and they want to get tested, this is PCR testing available currently 5 days a week. Mondays and Thursdays, 2 to 6 p.m., Saturday, 10 a.m. to 2 p.m. So I just really want to emphasize that. The city also has some information and a portal for reporting self-tests if somebody's done the at-home COVID test. And then that would also be followed up by somebody at the health department if consented, to provide guidance or answer any questions. And then also obviously COVID vaccination. So that's again at the norwalkct.org/vaccine link. Again, all this information I'm presenting here it's pretty much in the bi-weekly COVID-19 report. It's very comprehensive, and it's posted on the city webpage and the social media, Twitter and Facebook. So that is the current update relative to COVID-19. Thanks, everybody.
Thank you so much, Brian. Does anybody have any questions?
What is the current turnaround rate for PCR testing?
So it's anticipated from what we've seen, although we found instances where it could still take up to 5 days for certain results to enter the system, but somewhere within the 24 to 48 hours should be when the individual that's getting tested gets the results in terms of making it into the state database and consequently our data analyses. That usually seems to take 3 to 5 days.
That's right. Thank you.
I just want to share that Janet Karpiak, board member, joined right, I think, as Brian was presenting, so right at the beginning of his presentation. So we do have a quorum. So if it's okay with you, can we go back to look at the meeting minutes from February 22nd? Do we have a motion to approve? Dr. Umberger moved. Do I have a second?
Second.
Dr. Karpiak, second. Any discussion on the minutes? All those in favor, say aye.
Aye.
All right, passing unanimously. Thank you. Okay, all right. So our next item on the agenda is a reaccreditation update. So Megan.
Good morning, everybody. Good morning, everybody. Can you hear me okay?
Yep.
Okay. So my report is short and sweet. So we heard last week on our status of accreditation, and we did get reaccredited. And so that accreditation holds, yes, thank you. It's been a long process, but that accreditation holds for 5 years. So within the next 5 years, we will be submitting annual reports to FAB to just report on our status, continuous improvement for the department. We did show that we met all 12 domains, which is huge because there's multiple measures within all 12 domains. The first 10 domains are the 10 essential services related to 10 essential services of public health. And so that was probably our proudest thing, seeing that all 12 domains that were shown as met. Just really shows that the services and programs that we're providing here in Norwalk are really, at the highest standards they can be, but we're always going to look to improve the work that we're doing. So over the next 5 years, we'll be looking at, all of our services and programs related to the measures in FAB and make sure that we're, trying to improve where we can. Let me see what else. One comment that, within the report, the site visit team did give us was our commitment to the accreditation process during, a pandemic. And that really hit home. We started submitting, gathering our documentation in 2019. We were supposed to have a site visit in 2020. That's when we were supposed to have our site visit. We didn't have it until the following December 2021. So we had submitted documentation a while before. So having all of our staff to get back together, look back through documentation to remind ourselves of what we had submitted. It was really a trying time. And so without, my last thing, to thank all the staff and leadership, without all the great work that everybody does day to day, we wouldn't be able to show our department like this, but also asking everybody to, on top of everything that they do, to then get me documentation for reaccreditation and write narratives and review things and give me an example, and then I tell them I don't want that example, I need a different one. Nobody ever barks at me. So I really want to thank all of the, the whole team, all the supervisors and our leadership as well. I think that's it. I don't know if Deanna has anything else, but just thank you guys also to the board for all your guidance for approving policies when we needed you guys too. So thank you.
Thanks, Megan. So I want to thank you for all of your work to making sure we got through this process and leading us through it. Did such a great job. You started, you've been working on accreditation for many years, and you really are an expert, and people look to you across the state and even out from other states too for guidance on how to, how to lead a department through accreditation. So thank you for everything that you've done for us, Megan. It's really just really great. Aniela, she joined, and right away she jumped right into assisting us with accreditation where we were in the process. She learned quickly, picked up, and she really worked really closely with Megan to help assist us through this. So thank you, Aniela. And, I really have to thank the board, because you were the ones that set the vision for this with Tim Callahan, our previous health director, and really, pushed us towards this and encouraged us. And so really fortunate to have you all for setting that vision for us, and then also supporting us throughout the way and participating in all the different, processes, like from the strategic plan to the community health assessment improvement plan and the policies and procedures that Megan talked about, and all your great edits. I'm looking at you, Terry, for all your awesome grammar skills too, and helping us. So really want to thank you all for your support, and to the staff. The supervisors really, stepped up and did a lot and worked with all of their staff and performance management, again, policies and procedures, and just, again, what Megan was saying, the great work that everyone is doing, right? They're doing the work, and it's a matter of demonstrating that to the accreditation board. To Mayor Rilling, he's always been super supportive of accreditation. He has a lot of experience with police accreditation. He's been a national leader, he's been a site visitor in police. So he's always been super supportive of us as well. So just really, truly team effort, thankful for Lamont's encouragement, support as well. So yeah, it takes, a village, right? It takes everybody. And I'm really glad that we are accredited and we go through this process, because it really does make us better. So thank you, everyone. Go team.
And congratulations again. It is, a lot of us know it's a tremendous amount of work, and I really compliment the staff on their hard work and the accomplishment. Well done.
Thank you, Terry. All right, good work, everybody. All right. Oh, Dr. Weber, you're muted. I don't know if you're trying to say something.
I don't think there's enough words to praise that this whole community of people who've brought this together. It takes a huge number of people, a huge process of organizations, and your commitment to doing this is incredible. And I would hope that the city recognizes this work, particularly as we go into the budget process.
Thank you, Dr. Weber. So yeah, so fingers crossed so far, things are looking good. And that Mayor Rilling has been very supportive of the health department. So really thankful for it. And I do think it really helps demonstrate the value of the health department, right? And going through this process, showing the great work to everyone. All right. Our next item on the agenda is cannabis and health. So Several months ago, the American Public Health Association and the De Beaumont Foundation, they published a book that looked at, given the legalization of cannabis, how can policymakers design regulations that protect the health of the community? And so I saw this book and I spoke to Danielle about it. I'm like, this is, something we really should be looking at and thinking about, as the state has legalized cannabis, as Norwalk figures out what they want to do, how can we help inform and, provide the health perspective, the public health perspective into this. And so Aniela has been doing a lot of research and looking into this. And so we wanted to share it with you all and get your take on it. And yeah, so Aniela, I'm going to pass it on to you.
Great, thank you. So I don't know if I have screen sharing permissions.
Did you try or?
Give me a,
Yeah, I don't have any option to just share my screen.
let me see if I can make you a co-host and then you should be able to.
Oh yeah, I've got it now.
Okay,
Yes.
I have the power. Now you do too.
All right, thank you. So, all right, can you guys see my screen?
Yep, looks good.
All right, great. So, as many of you know, Connecticut legalized recreational marijuana or cannabis on July 1st of 2021. And we have an expectation that retail sales will begin at the end of 2022, providing that dispensaries and municipalities can make decisions that allow them to move forward. So Norwalk at this point faces two major decisions. And the first is because we are a city of more than 50,000 people, we need to find a place or designate a one public space where cannabis can be consumed publicly. So basically the question is, whether we're going to restrict public use to this one public space or restrict it to for all, so long as it's compliant with the Clean Air Act, which is what we see with tobacco smokers at this point. The second question is whether to permit cannabis establishments to operate within the city. So the first question that kind of falls under that umbrella is, will the city allow for cannabis retailers to operate dispensaries? Dispensaries are establishments that sell directly to consumers. And then the second question is, if we are going to allow cannabis retailers to operate dispensaries, will there be certain types of facilities around which a dispensary should not be located and zoning restrictions should be implemented? What we did as a city as of February 22nd was to impose a temporary moratorium on cannabis sales so that these questions would have, or so that the county council would have enough time to answer these questions. So now I'm going to provide you guys with a little bit of information on cannabis in general. So cannabis is a plant, also known as cannabis sativa, popularly known as marijuana. And it contains these chemicals called cannabinoids that basically attach to cannabinoid receptors that are located throughout the body and the brain. And the chemical that we're most familiar with is called THC, which induces sought-after effects of euphoria, relaxation, heightened sensory perception, laughter, all of the kind of thing that we think about when we think of the term getting high. There are multiple ways to consume marijuana, primarily smoking, vaping, dabbing, drinking, and eating. There are quite a few negative health effects that are associated with cannabis use. Some of them are acute and present during intoxication and just after intoxication. Those include impaired short-term memory, impaired attention, judgment, and other cognitive functions, impaired coordination and balance, increased heart rate, anxiety or paranoia, and acute psychosis that can be accompanied by hallucinations, delusions, and/or a loss of sense of personal identity. So some pretty scary stuff. And then the long-term effects can also be pretty chilling. Persistent difficulty sleeping, impaired learning, memory, and coordination, increased risk for chronic cough or bronchitis, increased risk of other drug and alcohol use, and an increased risk of developing schizophrenia for those people who already have a predisposition to it. Youth are particularly affected by marijuana use. There has been a ton of research that shows that teens who engage in heavy marijuana use do show disadvantages in neurocognitive performance, macrostructural and microstructural brain development, and alterations in brain functioning. And so one of the biggest alterations that we have seen is around mental health. And so there is a really big increased risk for depression or suicidality. And while that is a low risk for the individual, it is a high risk for the population given the scope of adolescents that are now consuming marijuana on a semi-regular or regular basis. As we know, marijuana is one of the most popular substances among adolescents. And the Norwich Partnership actually administered a survey in 2018 to gauge marijuana use, among other things, and found that 14% of 9th and 11th graders reported marijuana use, and 20% of those 11th graders reported regular use, which means that they have a pretty good chance of, having some of their population develop some of these negative health risks. Norwich teens also reported perceiving cannabis as less risky than other substances, so they're more likely to use it in comparison to others. And rates were higher among vulnerable populations, such as boys, Black youth, gay, lesbian, and bisexual youth reporting mental health struggles, and youth reporting antisocial behaviors. At this point, possession or purchase of cannabis by individuals under the age of 21 is illegal in Connecticut, but there is a big risk for it getting into the hands of youth. So at this point, every state that has legalized medical or recreational marijuana has done it in a different way. And so we haven't really had enough time to gauge the impacts of different kinds of laws and policies on the marijuana regime and how it's going to affect public health. We'll need at least one generation's worth of having people consume or purchase marijuana legally to be able to kind of figure out what the long-term public health ramifications will be. But right now we have, as a public health arena, kind of settled on a couple of public health priorities. And those are preventing youth cannabis use, controlling the prevalence, frequency, and intensity of cannabis use, not just among youth, but among everyone, reducing cannabis-related harms to individuals and communities, ensuring accurate information about the risks of cannabis use, and minimizing the influence of the cannabis industry and the profit motive in setting cannabis policies. So as I mentioned at the beginning of this presentation, we do have to consider spaces for consumption as a public health issue. So as I mentioned, under Connecticut law, public use of cannabis is generally prohibited wherever public use of combustible tobacco is prohibited. But we can, as a municipality, further restrict public use of cannabis by implementing bans or partial bans on public use through ordinance or through zoning regulations. Most likely we're going to go through zoning regulations because an ordinance would typically be a blanket ban. And as I mentioned before, because we are a city of over 50,000 people, we are required to designate at least one public space for consumption. So as we move forward and consider where to designate that public space, we need to think about a couple of factors that will play into that. First is the influence on observers. Do we want to have this around children? Do we want to have this around, people who may be more likely to be recovering from substance abuse difficulties to begin with, things like that. The second issue is secondhand smoke. There is a ton of evidence that secondhand smoke of cannabis has an impact on rats at this point. And so there is a lot of evidence that suggests that it will also have a negative impact on humans. And then the last consideration is that despite all of the negative health effects and the negative factors that we need to consider, we do need to come up with a safe and legal space for people who are going to consume marijuana to do so comfortably and legally and safely. Users of marijuana are most generally of a lower socioeconomic status and have less resources. And so we want to make sure that these vulnerable consumers who are more likely to be using marijuana to begin with are able to do so in a safe manner. The second issue that I described was spaces for retail. And so localities have to determine whether they want to allow cannabis establishments and to determine the time, manner, and place of these businesses. And so Norwich has to decide, number one, whether we want to have cannabis establishments to begin with. Number two, whether we want them to be dispensaries where they're selling direct to consumer. And number three, how we want these businesses to operate. So one of the biggest concerns that we need to think about is density and location of cannabis outlets, because they raise a lot of equity, public health, and safety concerns. Cannabis outlets at this point are already more likely to cluster in lower income and minority populated neighborhoods. There's conflicting evidence on the impact of outlet presence on neighborhood safety. For example, there is evidence that security measures such as lighting, having security guards, having signs around the area is a deterrent to some crime. However, because dispensaries are a cash run business and there is a lot of access to cash, there also is the threat of robbery by people who want to take advantage of a cash cow. So we do need to kind of be mindful that there are these two pushing forces against each other in terms of safety. The other thing that we need to think about is that historically, alcohol outlets have been clustered, similarly to marijuana outlets. And there have been a number of issues with excessive consumption and harms for both public nuisances and also graver harms such as DUIs, accidents, that kind of thing. So as Norwich moves forward, we need to consider if cannabis establishments are allowed after the moratorium. So as I mentioned before, should cannabis establishments be located away from certain high-risk facilities like those that are youth serving or serve populations that are at a higher risk, such as those in rehabilitation or recovery? And should density limits be imposed to prevent these clusters? In terms of advertising, which has been largely restricted by the state, because they put in place a rule that unless an advertiser has reliable evidence that at least 90% of their audience for an advertisement is reasonably expected to be 21 years of age or older, they cannot advertise. So that means anything in terms of print, media, radio, events, anything. If there is expected to be more than 10% of the events or audience being less than 21 years of age, they are not allowed to put that advertisement out. And that is because there has been a positive association between historically the marketing of alcohol and tobacco and outcomes related to use and health, particularly among youth. Unfortunately, a lot of these advertising rules have technically or historically had low compliance, and there have been not great enforcement regimens around these. So voluntary compliance with such state-level self-regulatory codes is often not the best way to go about things. And so we need to be mindful that if we do put in advertising rules, that we need to be sure to enforce them. Now, we can also consider the time, manner, and place of advertisements by further restricting zoning rules. And so we can consider a couple of options. We could implement a blanket ban, which explicitly bans any kinds of advertising and then explicitly describes permissible marketing activities. And so that helps people helps to prevent people from finding loopholes in the advertising system. We could also prohibit marketing on or within a given range of sensitive lands, so around schools or other facilities like that. But there has been evidence, such as in California, that dispensaries that are beholden to rules of not advertising to youth, those rules are often being broken. There is at least, in an instance of one California school, 74% of dispensaries within 3 miles of that school actually had one instance of interior marketing to youth. So again, it's a compliance issue and it's an enforcement issue. So we need to make sure that we are enforcing the rules that we set in place. And the last suggestion that I found in my research was to require visible health warnings on all advertising content. So to have it be, those big black boxes that say warning. And kind of going right off of that, like I said, consistency in enforcement and compliance is really key to equitably applying the law. Economically and socially vulnerable populations are the most frequent users of cannabis, as I mentioned. And so when we think about enforcement, we should be thinking about graduated enforcement. So, issuing warnings instead of harsher penalties to begin, and kind of minimizing those short and long-term inequities that do come up and that we are trying to avoid as we create a fair and equitable legal cannabis system. The other thing is that law enforcement has traditionally focused on individual violations, so a person who's carrying or in possession of cannabis, versus the role of cannabis establishments like dispensaries in doing ID checks and ensuring that they are only selling to people who are able to legally consume. So really we need to shift the focus onto dispensaries and that more systematic approach to ensuring that cannabis only gets into the hands of people who are legally able to consume. So with that, because as I mentioned, we do need about a generation's worth of data to understand what these policies are going to do in terms of the effect on public health, we are going to need a lot of surveillance on local consumption trends over the next decade that can provide us with insight on whether or not the policies that we do put in place are effective here in Norwalk. And with that, these are my references, and I'm going to turn it over to Deanna for questions.
Great, thank you so much, Aniela, for that great presentation. Do any board members have any questions?
Thanks, Aniela. That was really, really helpful. So I guess my main question is, I am assuming the Common Council has the authority to make those decisions, and we would be advising, is that correct? Yes.
Correct.
Okay.
Right. Yeah. So that's how I was thinking at, to the Common Council or zoning regulations. And so, however the city decides to go about it, I was thinking, it'd be important for us to be able to provide some information and, the research to help them make the best evidence, informed decisions on what they're going to be doing. So yeah, that's how I was thinking of it as, if the board wanted to, the health department and the board together, we could provide this information to them.
Right. I think it seems to me that there are more questions than answers, and this is a very murky and process, and potentially a slippery slope, and that's why a lot of towns have just put this off for a while. One of the questions I would ask is, what's going on in the communities around us, because I think that would impact our community.
So I did want to let you guys know that I have actually been tracking what's going on around the state of Connecticut. There is a master list that comprehensively tracks where each town is in terms of whether they've implemented a ban, whether they've implemented a moratorium and for how long, or whether they are allowing retail sales. And so what we're finding at this point is that Bridgeport is allowing retail sales. Stamford is on the fence, although probably going to allow retail sales. The surrounding towns such as Wilton, New Canaan, and Darien mostly have imposed bans. And so what we're thinking is we're going to see an influx of buyers, really, if we end up having an establishment, a cannabis establishment in Norwalk from the surrounding regions, because they are very anti-cannabis.
Yeah, exactly.
All right, so if there aren't any more questions, Aniela is working on a policy brief, like putting this in writing, summarizing all this research. So we'll be finalizing that right now. It's in draft, which is doing a great job. And the thought is that we're going to be sharing it with others to help, guide their decisions. So we will share that with you all too for your input as it gets closer. All right.
Deanna, do you still get the agendas for the Common Council? Like, will you know when it's on their agenda? If you could let us know.
Yeah, absolutely. I will. Yep.
Great.
All right. Aniela, you can stop sharing the screen, I think. Thank you. All right. If there's not anything else, our last item on the agenda is public participation, and I see we do have a hand raised. So Megan, can you add Ms. Diane Laurentella?
Yeah, I will.
Good morning, Ms. Laurentella. You're able, can you provide your public comment?
Yes, good morning. Very interesting meeting. My name is Diane Laurentella, 35 plus years in Norwalk. First of all, congratulations on the accreditation. I know it was long in coming, and at some point, I just wanted to know, can the public view the copy at some point, and where would we do so? But congratulations again, it really is amazing. I also want to thank Deanna Diamore and this board for the attempt of having evening meetings. I will try to help you do public outreach for when that next that next cycle happens. I appreciate that you are trying so more of the public can see all the good work you do. So I just have some quick questions related to COVID. And I appreciate, and I want to say, Brian Weeks' voice is terrific, and he should also consider a side business of voiceovers because he has a very positive, spunky voice. So he can make a lot of money on the side, just a thought. So it was very interesting to hear that report as well. I just have some really quick questions. Number one, exactly what efforts will be made starting soon to convey to the public how they still can reduce the chances of transmission besides vaccination? I know the federal government, state, and we are emphasizing vaccination, but that is not the only way to reduce the spread, whether or not we have BA2 or some new variant. So I would be interested in finding out exactly how can we be creatively conveying other reduction tools, including ventilation, masking for those who want to still wear masks indoors, distancing. I know I and some of my colleagues who know I'm kind of in the public health business, they and I have felt at times society, not Norwalk, but society has kind of now rewarded the anti-vaxxers and the anti-maskers. And those of us that really took a very responsible role in helping collectively in our society not have a spread. We would just want to make sure, because we know that this is not going away and you can't just snap your fingers. You all know that, but some in the public and some officials don't understand that. And lastly, my second question is exactly how will this department help increase the booster messaging and also the booster data, especially for those from age 10 to 19 and other adults that just don't think boosters are needed because the numbers are going down. And it's not an easy role, but what creative ways can we do public outreach and education, including, I would love to see some on the Board of Health who all are in their own rights, well respected in town, maybe do some public relations spots on Channel 12 or maybe the radio. I think some people listen to radio still, or something like that. So thank you for letting me speak, and I look forward to hearing back on my questions.
Thank you, Ms. Lortella, for your comments and your questions. I know perhaps we can do another update in future month about the community health workers and all that they're doing with messaging related to vaccination and all the other measures. Maybe we can go more depth to talk about that. I see Megan nodding her head. Okay.
Yeah, I was going to suggest that exact, all the work they're doing.
Okay, that'll be good. All right. Well, thank you, everyone. If there's nothing else, it's 8:53, so we can adjourn for today. Thank you again for moving your schedules around. And I hope everyone has a great day.
Thank you.
Thank you.